So now we'll invite Dr. Neeraj Sanduja, who needs no introduction, and he has a roaring practice at Gurgaon and prolific VR and cataract surgeon. He'll be speaking on neovascular AMD and cataract. Again, very frequently seen double trouble.
Thank you, Dr. Dipendra. Dr. Manisha. I'll be speaking on decision making in cataract surgery in cases AMD. So, as far as this surgery is concerned in this AMD patient, it is very important to counsel whatever we talk about. Whenever we talk about lenses, we talk about counseling. So, counseling is very important in such patients because these patients are having center involving macular degeneration, and the visual results are not going to be very great. And though we have seen vision mostly it improves whenever you operate such patients in form of improvement in contrast, improvement in total amount of the light which is going into the eye, and sometimes the visual results are very gratifying. And a recent study identified that the risk of fall in such patients decreased by 54%. In elderly age group, you can see the patients, they keep falling, injuring their bones and getting into fracture. So the risk of injury reduces a lot. So these patients should be given a trial of cataract surgery. It's very important. And this is quite debatable whether the cataract surgery causes AMD to progress. I've seen in my scenario 1 or 2 cases landing up into from dry to wet AMD out of thousands of patients. So I don't think that was just a chance finding. And even all the surgeries, they have been debatable. But we do tell our patients the AMD may keep increasing, but it will not increase the risk of progression of your AMD. So the patient has to be told in a very justified manner. And screening for macular disease with optical coherence tomography has changed the way we look at things. We all know about that. We don't go by only clinical examination, but OCT is an important tool. And the thing is, this question comes to us like how long we should give these patients with intravitreal anti-VEGF therapy before giving cataract surgery. So in general, a lot of studies, they have shown if you have been treating these patients for the last 6 months, if you do surgery after that period of time, patient is also mentally prepared, and also anatomical outcome in terms of deterioration of vision is much less because the disease has stabilized in most of such cases. And predicting visual acuity outcomes, it is challenging, but the poor visual outcome is mostly seen in patients where there is a longer duration of AMD in intermediate AMD, and ellipsoid zone disruption is very important to see. If ellipsoid zone is disrupted in neovascular AMD patients, so such patients, they are not going to get good vision, and you have to prognosticate such patients. As far as the intraocular lenses are advised, monofocal lenses are the lenses which should be preferred in such cases. No going for heavy profile, multifocal, monofocal with extended range of vision. All these lenses or EDOF lenses, they don't help such patients because already the contrast is reduced, and these lenses, multifocal lenses, they give higher order aberrations. So better to avoid such lenses. Go for monofocal. Tell the patient you have to use glasses for reading, and for distance also you may need glasses. And also sometimes you have to give low vision aid. So putting a multifocal lens is going to be a big no in such patients because low vision aid will not going to help such much in such cases. Toric intraocular lenses should always be put because we should try to reduce the astigmatism to as nil as possible. And aspheric intraocular lenses should be choice in such patients. And there has been a lot of debate about blue blocking IOLs, but it did not statistically significantly decrease the likelihood of further progression of neovascular AMD. So any lenses which we use for ultraviolet blockage and blue blockage, they do as good as like any other lenses. And there has been a debate whether we should put special type of lenses like telescopic lenses or Galen type macular lenses, because these lenses are indicated in a certain subset of patients where the total size of the lesion is less than 1 disc diameter, because these lenses, they are going to focus the light away from the center of the fovea, but the degeneration, whether it is a form of scarred CNVM or whether it is a geographic atrophy, it should not be more than 1 1.5 mm. So only those things it can help. And also in such cases, the anterior chamber depth has to be really good, because these are little bulky lenses. You can see, look at the design of the lens, quite bulky lenses. So anterior chamber depth has to be good. You can't use in glaucoma patients such cases. So this is the macula lens. It is kind of telescope implant which helps in improving the vision. Intraoperative consideration, it does not make any difference whether you give anti-VEGF at the time of the surgery or you give 1 week prior. But mostly generally we give 1 or 2 weeks prior to surgery as a standard protocol. But even if you give in the same day, it does not change your visual outcome. And such patients who receive multiple injections of intravitreal drugs, they are more likely to develop sometimes some micropuncture into the posterior capsule and zonular dialysis also. So you have to be a little extra cautious while operating such patients, because you can land up with some challenges of posterior capsule rent in such cases. And also you should reduce any unnecessary light exposure once the cataract is out. Once the patient is aphakic, you should not keep waiting. The lens should be loaded and you should put it as early as possible. And as far as the flux is concerned, the post-operative course between this conventional therapy and femto laser has nothing to do. Any surgery with a good surgeon is good enough. And such patients who have received multiple injections, they are more likely to have some complications of endophthalmitis. Various studies have shown. So you have to be a little extra cautious while treating such patients, keeping a close watch in such eyes for any undue amount of inflammation. So the conclusion is, there are quality of life benefits in carrying out surgery in visually significant cataract in patients with all stages of AMD. So preoperatively, you have to do the OCT and avoid multifocal intraocular lenses, and plan your surgery after at least 6 months you have given these intravitreal injections. And during surgery, you have to take care of any inadvertent PC rent and reduce unnecessary light exposure. Thank you.
Yeah. In near future. Excellent presentation, Dr. Neeraj, and I think you have covered almost all the points relevant to this situation, AMD patient undergoing cataract surgery. I think I'll just add that as far as this progression of AMD now issue is more or less quite settled in literature. Most reports now finding no progression. Even meta-analysis and all these studies.
Even real-world scenario, in our experience also, we have not seen any
I think the final conclusion is that it doesn't. Rather, if I see from different perspective is, after cataract advances too much, the sensitivity of your Amsler grid and other things to detect a small CNVM and metamorphopsia also goes down. And that is how we counsel our AMD patients, that even if you have a risk of converting to wet AMD, if you allow your cataract to progress to very advanced stage, you will not be able to judge it whether you are having metamorphopsia and other things. So it might be detrimental to delay cataract surgery in them for quite some for unnecessarily. Obviously, you will operate when there is a visually significant cataract.
And also, like the risk of fall means it reduced by 56%.
Other risk,
there's so many other things we are depriving them of. This,
only thing is to make them realize that your central scotoma. So what we do is, the moment they start developing cataract, you start telling them and start making them aware of their scotoma, that how much area you don't see. If they can start feeling it, they will accept the result of cataract surgery very gracefully, because they realize that scotoma is not going to disappear. And you rightly pointed out that intensive phase of CNVM management, when you deal with a treatment naive CNVM, is for 6 months. They are overburdened by too many visits, multiple monthly injections and OCTs. So probably we should delay the cataract surgery once this intensive phase is over, and you can do cataract in their maintenance phase when they are on PRN, coming every 3 months or 4 months for injections.
Correct. That breathing space has to be given to the patient.
Yeah, absolutely.
Otherwise, he will not stick to you. He will not stick to you also.
Because unlike DR, where you have to do laser, you want early cataract and early you want to treat the proliferative part, there is no urgency here.
But the counseling part is what it is, but as you rightly said, it is most important. What I say in the language is that if you have this ARMD, you have that central control that is not going to go.
Yeah.
But now what you are seeing is what we see in pollution, that once we upgrade it, you will see whether it is something like after after rain, there becomes clear. So the side thing will be better, but the central control will be better. So you need to counsel the patient what he needs to expect from you. But just ask one question. You were talking about those telescopic lenses. Have you seen any patients?
No, actually, care group, they manufacture. They came to me and told me the indications also. But I think we can use. Never had those guts to.
One of
but
our
I think
alumni, he was my group mate only, Dr. Amol Kulkarni. He was part of the trial for IMD. He shifted to US after his MD. So his first-hand feedback was this: there were very high incidence of decentrations, PCOs, and overall visual performance of these lenses. That's why even in there also they didn't use it after the trial was over themselves.
Okay, thank you very much.
Very nice presentation. And I would like to add that in early cases of AMD or the dry AMDs, you can go for premium IOLs. And also important that multifocal, they should be avoided in cases where you want to see the retina. You have to do indirect ophthalmoscopy and various other tests. So avoid. So in it, yeah. So 2-3 things are important, है ना? Early and dry AMDs. Go for any IOLs the patient wants. Whatever patient wants in those stages, but otherwise you cannot if it's a wet AMD. Now our next speaker is Dr. Dipendra V. Singh, who's practicing in Gurgaon. He's going to speak on cataract surgery with ERMs, how to deal with them, what's the double trouble he faces. That's it. It's the last talk of the session.
आपस में एक दूसरे को अपना
We are thankful to the
Thank you, Dr. Ashu.
Dr. Ashu.
For joining.
Dr. Ashu, thank you so much. He has given a lot of inputs to us regarding the IOLs. He's an anterior segment surgeon in Delhi, and we are thankful to him. He has added a lot of how to deal with the intricacies in special lenses. Thank you so much, Dr. Ashu. Yes. Thank you so much. Thank you.